the end.
Meeting is being recorded.
Because probably it will give us a more comprehensive perspective of the disease. And with that, I'll let Suja start. Welcome.
May I just...
Thank you.
Yes. Oh, sorry, I didn't present my co-chair. Benzan is co-chair.
Yeah.
Go ahead.
Yeah, that's not my point. I just want to ask also people that are online to switch off their microphone, because otherwise there is a lot of sound. Thank you for that.
Okay, thank you very much for the introduction. I will share my screen to share the presentation. And please let me know if everything works okay. Is everyone, can you see my, okay, perfect. So again, thank you for the introduction. My name is Susha Pinto. I'm a PhD candidate at Amsterdam UMC. And I will present a case that we have here in our center on the multifocal ectopic Purkinje related premature contractions. And this case is about a female patient. She was born in 1992 and she presented at age 7 in a different medical center in the Netherlands with a tachycardia myopathy due to incessant atrial and ventricular tachycardia. And because she presented in another center, we don't have all the information of her first presentation. But what we know is that her mother, aunt, and cousin are also known with the familial arrhythmias. And that she presented with episodes of nausea without vomiting and fatigue. And that her initial treatment consisted of the following medications: so propafenone, captopril, hydrochlorothiazide, aldactone, carnitine, and digoxin. And that is what they initially gave her at age 7. And then what I could further find from that beginning of this case is that they did a 24-hour EKG where she had a PVC burden of about 11%, with 1,500 solitary PVCs and over 5,000 couplets, and that they were the PVCs were predominantly at night at a lower heart rate, and that notably she always had sinus rhythm during exercise. They also described a echocardiogram where they described that she had a dilated left ventricle with a poor shortening fraction. And just as an illustration, because I also didn't have an ECG of that first presentation, but this was the first one that we have in our center, to kind of give you an idea of what she presented with, and to see the frequent here, as you can see in Gemini, the premature ventricular contractions. And then a question to maybe Vincent or Elena, because this patient consistently had sinus rhythm during exercise, yet her cardiologist at the time advised restricting sports. I was wondering what would you as experts say on this, and what is your current recommendation on this?
Go ahead, Vincent. I think, or will you answer this question during the presentation?
Not really. So, because in fact, we have very few information for now on how it's happened for the patient. What's the risk of sport activity in this kind of patient? As you mentioned, it's quite usual. I would say it's normal for this specific pathology to have the VPBs that disappears during exercise, exactly as you showed. But is there still a risk of different ventricular arrhythmia and sudden deaths in this situation? My answer would be that you have no clear data for that, but my answer would be that if the ejection fraction is normal, it's certainly or subnormal, it's certainly possible to allow sport activities. I would be a little bit more restrict in case of low ejection fraction. For your case, it's mild decrease of the ejection fraction, and then I will probably not restrict sport activity in this specific patient.
Okay.
I
Thank you.
completely agree. Actually, the key defining probably at this point is whether the patient has significant left ventricular dysfunction. And just to add something to what Vincent is saying, is like you put them on the treadmill. If you see that they don't have complex arrhythmias, it's kind of, I would do that. It's not that there's much evidence to they say you're completely safe, but if there's no significant LV dysfunction and no arrhythmias with exercise, I would probably also let him or her keep doing sports.
Yeah. Okay. Well, thank you both for your answers. And in fact, what I read later on is that she did do some horse riding and some light sport activities. And when she asked about playing soccer, the cardiologist restricted that a bit more. But she did gradually do a little bit more sports later on. So she presented, as I previously said, in 1999, but then initially she improved with her treatment, and then in the end of 2001, beginning of 2002, there was a sudden disease progression. She had increased ventricular arrhythmia burden and a worsening of her LV function, and she also had AV conduction disorder. So the plan then was to have her admitted at the hospital for propafenone uptitration, and she received a dual chamber pacemaker. And after that, she was stable for several years with the following medication, quite similar actually to her initial treatment, just without the digoxin. And then a few years later only, so this was all while they weren't sure what exactly was the underlying genetic diagnosis. And then around 2011 is when they found the diagnosis. They found a SCN5A R225Q variant, which we now know is associated with the MEPPC syndrome. So then in 2008 is when she first came to our center, and she was first admitted for flecainide initiation with initially a adequate response, but then later on during exercise testing, she did show a significant QRS prolongation while on flecainide. So they stopped the flecainide again, and her therapy consisted of the propafenone, carnitine, and the aldactone. It is noteworthy to mention here that they did see some QRS prolongation on this therapy treatment as well, on the propafenone, but it was less than with the flecainide. And then in 2012, because she still had ongoing frequent PVCs despite her medical therapy, they admitted her again for quinidine initiation in our center, and she had a good response on that, and her left ventricular ejection fraction previously was around 40%, and with the initiation of quinidine, it improved to about 45 to 50%. And that is what she is still on today. So her treatment for today is still what it has been since then. So the quinidine, the carnitine, and the aldactone, and that has significantly improved for her. Another question for one or both of our moderators. She already has a dual chamber pacemaker, but when would you consider an ICD in a patient? And is your first line therapy also flecainide or quinidine, or is this dependent on your left ventricular ejection fraction?
That is excellent question that I will try to answer with my presentation later.
Perfect. Okay.
If you agree.
Then I will skip this further, and then we will hear it later on. Thank you, Vincent. I just wanted to quickly show, this is what her most recent EKG is like with her current treatment. So as you can see, that is quite the improvement from what it was before. And then a quick question still before I tell you the last part of this case. And maybe it is something you will talk about, Vincent, but what is your approach to managing this MEPPC during pregnancy? Are there certain drugs that are have to be continued or should be stopped? And how closely would you monitor mother and child? And at what age would you recommend genetic testing for the child?
For the managing of pregnancy, there is for now few information about that because there is in reality very few cases of MOPPCs that are published for now, and in each center the number of patients is very low. So but on what we have as information about that is that for now we don't have information about bad evolution during pregnancy for this pathology. As pregnancy increase heart rate and as VPVs decrease with increasing of the heart rate, then it's quite logical that there is no bad evolution in this situation. The question that you can have is it possible to maintain drug therapy? For flecainide, that's clear. For quinidine, usually it's possible also. So I will maintain the treatment during the pregnancy. For the monitoring of mother and child, I have no clear answer for that. But I would say, but it's highly debatable, that I will probably perform Holter recording in the mother every 2 or 3 months, something like that. And that's it. And echo, and also echo cardiogram, probably at the beginning of the pregnancy, let's say at 2-3 months, and also at the end of pregnancy, especially if the mother do not have decrease of the left ventricular ejection fraction. I'm not sure that I will perform echocardiography during the pregnancy, but in case of mild to moderate decrease of the ejection fractions, then I will probably monitor that during the pregnancy, just to make sure that that will not deteriorate the ejection fraction. For the age of the genetic testing for the child, I would say at birth. Even if I don't have a case of very, very young child affected by the disease, but it's happened quite early during life. So I would say that it's probably better to know rapidly after birth if the child is at risk or not. But also for that, it's just my feeling. It's not something extremely clear.
Maybe we can leave it for later for the discussion, but I would add that monitoring the fetus, you can perform also the echo for the fetus, because I mean these are very, very rare. I've never had a case of that, but maybe the fetus is already affected and you can see the PVCs in the fetal echo. And especially, I mean, I'm just talking about hypothesis, and I would like Vincent's perspective, but if the mother is still on quinidine, there's some placental treatment, you may have withdrawal, let's say, syndrome if the baby is a carrier and suddenly stops having exposure to the drug. So I think that some kind of echocardiogram for the fetus to actually detect if there are some PVCs or conduction disorders or anything that may suggest that there's a problem with the fetus, I think that it would be useful probably to plan the early days until you have a genetic diagnosis and the ECG, of course.
Yeah. Okay. Thank you very much, both for the answer, and maybe in something interesting for later in the discussion. To round out my case presentation, this patient got pregnant in 2023, where her treatment was continued, although the Electron was discontinued for the duration of the pregnancy. And indeed, in this patient, at about 24 weeks of pregnancy, they found an irregular fetal heart rhythm in the fetus. and they noticed that it were premature ventricular contractions in bigemini. So they monitored the fetus every 2 weeks with to monitor the heart rhythm, and they found that it was intermittent. So sometimes they would find a irregular fetal heart rhythm, but at other checkups they didn't. And they indeed, as you said, Vincent, they did immediate genetic testing. So they took umbilical cord blood and they did genetic testing and found the same variant in her son. And her son is being followed up at the pediatric cardiologist at our center. And his EKG and Holter monitoring and echocardiography are reassuring, up to date. So no treatment has been started for him yet, but they are having him in follow-up. And then to finish this off, and maybe again, this is something you will talk about, Vincent, but what would be in general the follow-up strategy? How often would you see this patient, the female patient, in terms of frequency of the follow-up? And would you do a Holter monitoring for every follow-up and an echocardiography for every follow-up, or do you do that less frequently? And then the last question, in case of drug intolerance, are there other antiarrhythmic strategies? In our center, Dr. van der Werf and Professor Wilde, they just wrote a case report with some colleagues on the use of ranolazine in a ME-PPC patient.
If you agree, we can try to answer these two questions also at the end of my presentation.
I think it makes sense. Yeah.
That's okay.
Any pressing question from the audience, or would you wait until the end after Vincent's presentation and we do the general discussion? Let me see. Okay. If I speak, because I don't see everybody's faces. Okay. If nobody speaks, I think we can proceed with Olivier van Leuven to present his case.
I will stop sharing. Yeah. Thank you.
Thank you. Very nice case.
All right, you can see the presentation?
Yes, we can.
Great. Okay, thank you for the nice case, Susha. So we like to share another quite similar but not the same case of a young female patient who came to our cardiology consultation for the first time approximately 10 years ago, when she was about 30 years old, because of palpitations and fatigue. She did not have any syncopes. She had no medical history, no medication. And this is the first ECG at presentation. So you can clearly see that it's at least irregular, a lot of extrasystoles. You can discuss whether it's supraventricular or ventricular. So the first thing that was done in this patient was ambulatory 24-hour Holter registration. So what's quite remarkable is that on this Holter registration, it was said that there was a very high supraventricular extrasystole burden, so 47%. It did not show any ventricular extrasystole, but there might be some discussion about it, because here you see a part of the tracing of the Holter registration, and you can clearly see it's irregular. You can recognize supraventricular beats, but probably some ventricular extrasystoles as well. So this patient had an ultrasound, which showed a mildly reduced ejection fraction, about 45%. On MRI, a bit less, approximately 40%, without any dilatation, hypertrophy, or late gadolinium enhancement. One very striking part of the case is that this patient had a sister who was about 4 years older than her, and she had a history of peripartum cardiomyopathy. She was in follow-up with another cardiologist in another country. She had an ejection fraction of 31%, so quite low in comparison to our patient. And it was diagnosed after her pregnancy. So she had a dilated phenotype, which did not recover after pregnancy. She also complained of palpitations. And since the diagnosis of peripartum cardiomyopathy, she was prohibited to be pregnant again by her cardiologist and her gynecologist. So at that time, we had a patient with some unclear Holter, unclear ECG, and someone had the idea, let's see what the pathophysiological mechanism behind this case is. And she was sent for, I know it's a bit atypical to do it, but she was sent for an Ashmelin test. So here you can see the start of the test. The ECG is very similar to the ECG we saw at the consultation. About 7 minutes in the test, so that means 2 minutes after maximum dose, we still see irregularity, we still see extrasystoles, but 3 minutes after peak dose, so 8 minutes in the test, there was a complete resolution. There were no extrasystoles, no irregularity on this ECG. So if you make a quick roundup, we have a young female patient with a very strange, very suspicious family history, a mild to immediate reduced ejection fraction without clear structural pathology, and complete resolution of the arrhythmia with Ashmelin. So at that time, the team said, well, she has a reduced ejection fraction, she has a very high burden of arrhythmia, she needs an EP study, she needs an ablation. So she was sent for an ablation, and at the table it was seen that she did have a 50% extrasystole burden, but it's more a ventricular and not a supraventricular, as been said in the Holter registration. What you see here is a map of the right ventricle, and they saw that the early activation was in the distal His region, but earliest activation, it was on time with the service QRS. It means it's early, but not early enough. This is not the focus. This is not the exit of the PVC. So it was decided to go to the left ventricle. And on the left ventricle, the earliest activation was in the proximal left anterior fascicle region. So also in the native conduction system. There was a nice signal there. Ablation was started, and during ablation, they saw that the extrasystole, the morphology of the extrasystole changed. It changed to a left bundle branch block. So it means that it's not anymore on the left, but it's on the right side. And when they mapped on the right side, anytime they thought they found the location, there was mechanical suppression, and the exit shifted closer, closer, and closer to the His. So to round up this EP study, there were clearly multiple septal exit sites, clearly very close to the His, to the conduction system, so a very high risk in a young patient for permanent complete AV block. In a patient in which we actually do not know what the underlying disease is, so the procedure was stopped, and it was declared a failed ablation. And it was decided to wait for the genetic testing to proceed with any other therapies. So, surprise, surprise, when the genetic testing came in, there was a variant in exon 6 of the SCN5A mutation. But then the question is, what does this mean? What does this mean for our patient? What do we have to do with it? What's helping us in therapy? And I want to remind you all of this very nice paper which is published in 2012, in which they showed that this kind of mutation is associated with a reversible ventricular ectopy and dilated cardiomyopathy. If you see at tracings on the bottom, you may think that they're quite alike the ones we had in our patients. And what did this paper tell us? Well, the SCN5A mutation we found is a gain of function mutation. So we have a diagnosis in our patients. The diagnosis is multifocal ectopic Purkinje-related premature contraction, probably complicated with tachycardiomyopathy. At that time, we had a diagnosis. We have a clear molecular mechanism. We have a clear molecular diagnosis. And it was discussed to start flecainide. And it may sound a bit strange because as a cardiologist, we are trained if the ejection fraction is low, you never start flecainide. But in this case, since we had a really clear mechanism, it was started, and it was a great response. So the extrasystoles disappeared completely. It was like 3 extrasystoles. It was not just coincidence. It was repeated on next Holters. All the extrasystoles were gone. And on top of that, we had a complete restitution of the LV function. So everybody's happy, but patient comes to the consultation and tells us, yeah, well, I'm 30 years old. I want to have children, and I'm a bit scared for it because, yeah, my sister, you know, with the peripartum cardiomyopathy, and they told her never to have kids. Right now, we have very nice guidelines for it. At the time, that was not the case. So if you look at the guidelines right now, they show us that if you're at atrial or ventricular ectopic beats without LV dysfunction, you can get pregnant safely. Of course, it's a broad group. It doesn't really define this specific subgroup, but it can help us in the decision. At that time, there was more worry about flecainide during pregnancy. Right now, the guidelines say it is feasible, although there are some animal studies who still say it's not that safe, especially during first trimester. So there was a question, should we change? Should we go to quinidine? And should we go to pre-implantation diagnostics? So we had an open discussion with the patient, shared decision-making with the team. First, there was a switch to quinidine. They saw the PVCs still were gone. The burden was low. There was still a low ejection fraction, there was a normal ejection fraction, and the pre-implantation genetic testing was started. So this patient was enrolled in a pre-implantation trajectory. She got pregnant, and she was followed up during with help of our pregnancy heart team, with regular visits, with regular ultrasounds. She had a very normal pregnancy, normal birth without any problems, and no signs of peri or postpartum cardiomyopathy. And the final result is that we have a happy mother with a normal LV function who has 2 healthy children who are not carrier of the diseased gene. And yeah, the sister came to consult as well. She's treated with flecainide, and her function has recovered. So what are the key points of this case? I think it's preaching to the choir, but family history provides vital clues of cardiogenetic diseases, of course. Always be aware of a high burden of non-outflow tract PVCs. It's always a bit shady. Also a high burden of supraventricular extrasystoles combined with a reduced ejection fraction. It should always trigger further investigation. In this case, not pursuing acute ablation was the only right answer, the only right way to go. Of course, cardiogenetics can solve the mystery cases, strange cases. And in this pathology, you have really a molecular diagnosis with direct translational mechanisms. So it allows us to start with personalized management. In this case, flecainide restored function. And I know it may still sound a bit controversial to start flecainide in a reduced function, but we think it is the way to go in this kind of cases. Of course, solving cases like this requires all of us at our best. We have to turn a complex case like this step by step into a very simple answer with long-lasting effect for the patient and families. And I think this is also a case that shows that primordial prevention with pre-implantation genetics can really help patients and their families. So with that, I'd like to thank you for attention.
Thank you. Also a very nice case. And I think both of you have shown how important it is to look at the patient as a whole, because they have their everyday problems, in this case, both pregnancies. Is there any quick question from the audience? If so, just go ahead and talk. Otherwise, I'll let Vincent Prost solve most of our questions with his presentation. Vincent, I think it's your turn.
Yeah, I will try to do so. So can you see my presentation?
Yes, we can.
Okay, perfect. So I will try in the next few minutes to summarize what we should know for now on this specific pathology. The story of MOPPC starts with, in fact, with this family that was initially identified by Gabriel Laurent in Dijon, in France. As you can see, this is a relatively large family, and at this time, that was in 2010, something like that, Gabriel asked me if I can help for the diagnosis of this family, because he found several family members. I will not show all the ECGs that we have, but as you can see, this one is very close to what has been shown before. That is, in fact, not so simple to describe. Because there is a lot of different things of this ECG, and to tell the truth, when we prepare the manuscript that we published in 2012, we spent a lot of time looking at the ECG to try to find the good way to explain what we can see on the ECG. But as you can see, there is a lot of VPBs what we consider as VPBs, and here is easy because you can see the P wave after the QRS with VPBs close to other complex like CIS1. That is not a sinus complex, as there is no P wave before, and at other moments, other morphology on the ECG, but what we always found is whatever the morphology of the QRS is something relatively sharp, not wide QRS, and with a lot of different aspects. This is in one example. Here is another one. This time this is VT. Also with right bundle bushbelt patterns, not very large. You can see that on AVF, for example, you can see some modification of the QRS, not also so easy to describe. And here again, another ECG. This is the two first are from the same patients. This one is from another family members, where you can also see that there is a lot of different aspects. For example, here you can see on 4 different QRS, you have 4 different aspects, and still another one again here. But all these different VPBs are always relatively sharp. This is not wide QRS, and it seems to come always relatively close from the East bundle with different aspects. Here again, another family members that also had a very strange ECG, I would say. Again, you have some complex that seems to be normal complex of the patient, but without P wave before the QRS complex, and other complex that are different. Here we have you have a left bundle pattern, and also a lot of change from one complex to the other one. That is really the clear characteristic of this pathology. In this family, Gabriel tried to perform some ablation. It always failed. This is a clear example where you have all the different occurrence of the VPBs on this map. And you can see that you can have 9, 10, 11 different occurrence of the VPBs that explain extremely easily that it's just impossible to ablate. Otherwise, we will have to ablate everywhere. That is not feasible. And also, as it has been mentioned before, VPBs are coming close from the East bundle. And at the end, if you want to perform the ablation, the complete ablation will ablate everywhere, and you will destroy the East bundle and the Purkinje, all the Purkinje fever. 2 weeks after I was contacted for the first family or something like that, we were able to find in this family this mutation. That was the first mutation related to this strange pathology, GR222Q mutation. And 2 weeks after, as I said, I was contacted by a Parisian colleague, Elisabeth Villain, that asked me for advice on the management of this second family that is not exactly the same pattern, but very close to what I showed you before, with also here QRS complex that is escape complex, I would say, with no P wave before, and a lot of VPBs, that is here left bundle branch block pattern VPBs, but also with some change from one complex to another one. And this is here another patient from this family. And then, as it looks like, it's not completely the same thing, but it looks like the same kind of VPBs that we found in the first family and the same time of aspect. Here is again a really nice ECG that is really characteristic of this pathology. With you have some kind of 3 times shape of the QRS 1, 2, 3, 1, 2, 3 that is very repeatable, and you have a lot of VPBs again with a lot of different morphology, and then we go directly to the sequencing of the specific mutations that we found in the first family, and then found exactly the same mutation in the second smaller families. And then we asked to our colleagues from Amsterdam, I sent an email to Arthur asking him, we have found something strange. We found the same mutation in both families. We think that we have something very special. And do you have any other families that would look like what we found in the first two? He had another one family, and what we found in this family is when we try to summarize the clinical information, it's first that it's happened early in life. You can see that, for example, we have a very young child, 4 months old, that had sudden death. There is a relatively high risk of sudden death within the 3 families. We found that in some patients, there is a left ventricular dilation with a decrease of the left ventricular ejection fraction. And Gabriel already start to use quinidine just to see what's happened. And there is already a very good response in some patients with improvement of the left ventricular ejection fraction. And when we described all these different ECGs that we found within this different family, what we finally found is that there is some paroxysmal atrial arrhythmia. This is not a major finding in the families that depend on the family. You can see that in the family 1 and 2, that's not very frequent. It seems to be more frequent in the family from Amsterdam. When we describe the PVC, you can find all type of PVC, but always narrow QRS during the PVC, or almost always narrow QRS. But you can find right and left PVC morphology with right or left ventricular axis. Junctional rhythm is extremely frequent, almost in all cases in reality. That is clearly a part of the diagnosis. And when you look at the frequency of VPBs, that is really the characteristic of this pathology, that you have extremely high number of VPBs in most of the patients, sometimes more than 50,000 per 24 hours. There is not a lot of EPS, but when EPS was tried, it failed each time. And what is also extremely characteristic, because at the very beginning we think about ventricular tachycardia, ventricular catecholaminergic tachycardia, but when we look at the evolution of the VPBs during exercise, that's systematically, completely disappear. Then, as in some patients, hydroquinone seems to be extremely efficient, then we propose for most of the family members carrier of the mutation and having the ECG abnormalities to try hydroquinone, because we can have hydroquinone in France. And as you can see on this slide, the results of the treatment was absolutely fantastic, with almost complete disappearance of the VPBs in the vast majority of the patients. And in most of the patients, a normalization of the ventricular ejection fraction, even if some of these patients was close to heart transplantation at the time where we start hydroquinone. As you can see, there is some case of sudden cardiac death. And for the medical treatment, in Amsterdam families, they used flecainide that seems also to work extremely well. That is not the case for propafenone in this specific patient, but propafenone seems to work less than flecainide or hydroquinone. Then we perform on the mutations that we found in these three families patch clamp evaluation, and we can see there is a left movement of the evaluation on patch clamp for both activation and deactivation of the sodium channel that lead to an increase of the sodium windows. And when we perform modelization of the effect of the mutation on computational model of our Purkinje cells, you can see that we can have DAD at lower heart rate, but when we increase the heart rate, there is a complete disappearance of the DAD that fit very well with what we found in these different families. And then when we look at the effect on hydroquinone on the mutation on cellular models, you can see also that with quinidine, there is an almost normalization of the effect of the mutation that fit very well with what we found in the family, with the excellent effect of hydroquinone in this family. As we, at the time where we performed the patch clamp analysis, we had at this time only the French families and treated with hydroquinone. We didn't test the effect of flecainide on this cellular model. So in summary, in this first family with the same mutation, what we found is a net gain of function of the sodium channel with an increase in Purkinje cells excitability that really is fit perfectly with what we can see on these different families. And after a lot of discussion, we finally decide to use the term of MOPPC. I'm not sure that's the best terms that we found to describe the pathology. It's described well, the pathology, but it's not an easy word to remember for the people that want to describe this kind of pathology. That is characterized with the presence of multiple PVC with relatively narrow QRS complexes, typical of left and right bundle branch block patterns, indicating an origin from fascicular Purkinje systems, extremely sensitive to hydroquinone and flecainide, with transient tachycardia DCM-induced syndrome, and a potential risk of sudden cardiac death. In contrast to the other SCN5A associated arrhythmia phenotypes, there is no abnormality of the ST segment morphology, no QT prolongation. The number of PVC decline during exercise, likely due to overdrive suppression, and the structural changes on the atria and in the ventricle disappear with the treatment of the arrhythmia if the treatment is started soon enough, because if it starts after a very long period of time, then it's too late and it's not possible to retrieve a normal ejection fraction. Because if you wait for a long time before treating the patient, you then have left ventricular fibrosis and no recovery of the ventricular dysfunction. This is a summary, a recent summary published on all the cases and all the small series of patients that have been published for now for what we call now MOPPC. As you can see, there is essentially a case report, very few relatively large series. And in fact, there is extremely few series of patients, except series from Denmark. This one is not really a series of patients with MOPPC, because this is only patient with long QT3 syndrome that should have the same kind of VPBs. But for the rest, it's small serious patients that is, you have here all the different mutations that is considered to be responsible for MOPPC. You can see that the two most frequent is, the most frequent one is clearly the HER222Q mutations that we initially described, but there is also several families carrying of different mutations that are in fact close to the initial one. And as this is clearly a rare disease, it's much than interesting to have international registry to try to get enough patients to be able to depict more in details what we can have in this kind of pathology, because as that has been asked during the two first presentations, there is in fact a lot of question unanswered in this specific situation, just because we don't have enough data for that. So that's the reason why we start this ERN registry. We already have 57 patients included. That is not so bad, because it's a very recent registry. There is 19 provinces. The mean age was around 30 years old, with a small majority of females. Most of the patients have HER222Q mutations, but we also have some patients with the other mutation. Most of the patients are symptomatic at the time of the inclusion. You can see that is mostly palpitation, heart failure, some case of sudden cardiac death and syncope. 25% of this population had DCM at the diagnosis, and with 45 patients of the population with an ejection fraction less than 50% at the time of the diagnosis. The PR, QRS, QT were normal in all the patients, or almost in the patient, and in some patients there was some conduction abnormalities, but it's not something frequent in this population. When we look at pacemaker and ICD implantations, there is in reality a relatively large population of patients implanted with an ICD, more than 25% of the population. There is a lot of attempt to perform ablation in 25% of the population. It always failed. And when we look at the evolution of the evolution in terms of appropriate or inappropriate therapies, there is in fact relatively few appropriate therapy, only in 4 patients. That is not very high compared to the number of patients that have been implanted. And that is clearly an important question. Do we have to go to ICD implantation in this population? Now, if we look at the effect of medical treatment in this population, there is clearly 2 treatments that should be proposed in this population, flecainide or hydroquinidine. It's difficult to determine if one is better than the other one. For me, there is no clear demonstration that hydroquinidine or flecainide is better, so you can use both depending on what is available in your country and what you are more comfortable to use. Beta blocker failed, clearly. Amiodarone failed, clearly. And the other treatments that have been tested in this population, propafenone and all the other treatments, also failed. So clearly, it's better to go to flecainide or hydroquinidine and perhaps ranolazine in some cases, but we don't have ranolazine in France, so it's difficult to me for speaking about that. In conclusion, MOPPC is extremely easy to diagnose when you already have one patient with that, because when you already have that, I have another cases that I have to deal with 2 months ago, coming from another center, because the center asked me, we don't know what to do in this patient. He had a lot of BPBs. We don't understand what's happened. And in fact, just by looking at the ECG, you can say it's MOPPC. There is no question about that. Do not put an ICD, just try it with flecainide, and you will see what's happened. This patient was initially sent to my center for ICD implantation and potential heart transplantation because very low heart left ventricular ejection fraction. We start quinidine. 2 months later, absolutely nothing in this patient. No VPBs, normalization of the heart rate. And then we looked at the family and we found 3 other family members also carrier of the mutation with different severity of the disease, but all respond perfectly well to hydroquinidine treatment. So when you know it, it's extremely easy to treat. And when you look at the old publication demonstrating the presence of DCM in SCN5A carrier patients, when you look carefully in this publication, you find, in fact, a lot of VPVs, and most of them are probably related to MOPPC. There are risk of heart failure and sudden cardiac death if non-diagnosed, and you have seen that in our different families as initially, we just don't know the possibility of this pathology. There is some case of sudden cardiac death. Flecainide and hydroquinidine are very efficient. This is definitely not good cases for ablation. And the question for which I have no answers for now, is it necessary to go to ICD implantations? In my view, probably in most patients that is not necessary, especially if you have a good response to medical treatment and you can wait until you have the evaluation of the VPBs under treatment. The effect of the treatment is very quick, so you can wait for 1 or 2 weeks. That's enough. Probably MRI is very useful in this kind of patients to see if you have a lot of fibrosis. In case of severe fibrosis, potentially it's better to go to ICD implantation. If no or few fibrosis, you can wait until there is a recover from the ventricular functions. And you see that we just start this ERN registry. And if some of you do not have put their patient in the registry and you want to do so, that should be very interesting, because if you can have more patients in the registry, you can have the chance at the end to better describe this very strange pathology, in fact. And I guess it's really something important, because that should be extremely severe, with sudden death, severe heart failure. And we already have extremely efficient treatments that can really change completely the prognosis of the patients, and with, at the end, really easy treatment. Flecainide, hydroquinidine is not difficult treatment to give to the patients, with really exceptional results in most of the patients. Thank you for your attention.
Thank you. Thank you very much. I think it's been an outstanding afternoon. We have very few minutes for the discussion, but I believe there are some questions that we could address. We can extend 5 extra minutes beyond the time. So is there any question from the audience? I'm gonna ask you one that's on the chat, and then I'll open up for the people, or ask you a couple that I have. So the question on the chat says that the ART 222Q is not so rare. So do you have information on a potential founder effect?
Yes, we have, because that's what we check at the when we initially identify the 3 different families. One from Paris, one from Dijon, one from Amsterdam, and we check to see if there is some relationship, and if there is an founder effect on these 3 families. That's not the case. It's clearly possible that for other families that should be the case, but there's no founder effect on the 3 families that we identify initially.
Okay, I'm going to continue if there are no other questions from the audience regarding genotype. So we have a very clear phenotype, and the ECG, as you say, once you see it, you start to recognize it better. But I see that this small series and the case reports published, most of them were associated to a SCN5A variant. So we're not really aware how many cases do we have that are gene elusive, or because also the other thing that you see on the publications is that penetrance is full penetrance, right? So, or it seems from the publications. I'm not saying that that it is. What's your take about genetic testing yield? If you have a very typical ECG, do you still consider the disease if you don't see a variant on SCN5A?
Yeah. It's not an easy question to answer, because for now, the description of the phenotype is in relation with the presence of the mutation. And that's one of the questions that we had at the initiation of the registry. Is it possible to enter patients in the registry without SCN5A mutation, one of the SCN5A mutation that we described in the different publication? We have some rare cases of ECG that seems to be very close of what we described in this different family without SCN5A mutation. Is it really MOPPC syndrome or not? Difficult to say. My feeling is that probably yes, if we really have the same kind of ECG. We finally decide that this kind of patient should be entered in the registry. And at the end, perhaps we will find that there is some differences with the classical form with SCN5A mutation, and then we will have to remove it. But it's still interesting to include this kind of patient in the registry. As this patient is for now, but it's just perhaps because they are just not described, but as this patient is very, very rare for now, I have no information by myself on the effect of quinidine or flecainide on this kind of patient. So I cannot say for that. And what is your second question?
So the penetrance of the variant.
Yeah. For the penetrance, it's almost complete. We have some cases, but within the family, it's probably more than 90% penetrance, clearly. But there is some cases of patients carrier of the mutation with, I will not say not penetrant patients, but with only very few VPBs. The VPBs that in the normal life, you will consider that this is almost normal to have this kind of VPBs. I would say less than 200 per 24 hours, something like that. So these patients should be considered as not really with normal left ventricular ejection fraction. So you can consider this patient as almost non-penetrant.
Mild form, yeah, or
Yeah,
almost
or very mild form, something like that. Yeah.
So Johan Senen has another question. The R219H SCN5A variant has been shown to cause transmembrane proton leak, leading to Sarocke gain of function in the sodium channel. From the registry, is there information on a differential efficacy of medical treatment in these patients? Difficult question.
Difficult question.
Have you analyzed it?
Very specific question. I just looked at the result of the registry last week. So I didn't have time enough to go very specifically on detail of each mutation, but possibly the registry will give the answers for that. I can check for that.
Okay.
Because if I remember well, we have at least some patient with this mutation in the registry, but for now I am not able to answer. Sorry.
So I'll give you another strange case with no SCN5A variant for your registry. So you have two in the weird cases. But with this family, I started seeing this patient because his uncle had Brugada syndrome. And I did not, so flecainide test was negative. In fact, he had a lot of PVCs at rest, and with flecainide, they disappeared. We never found the variant. When I was on maternity leave, somebody sent him to the EP lab for PVC ablation for some reason, and it was actually not good for him. And in fact, he had increase of the PVC burden and ended up with a big chaos. So now he's on treatment with flecainide plus quinidine, so both of them. Do you have a escape route? So if quinidine and or flecainide don't fully inhibit the PVC burden, how would you approach that?
Yeah, we have some cases like that. We always have a good response with hydroquinidine, but in some patients, there was not a complete response, meaning that as far as I remember, there was no patient that do not have a decrease of the PVC burden using hydroquinidine. First thing is to check if the dose of hydroquinidine is correct. It's not specifically for this project, but we perform a randomized study on the effect of hydroquinidine in Brugada patient. The study failed. But during this study, we asked to systematically measure the hydroquinidine level in blood sample. And as for a lot of other treatment, there is a huge variation from one patient to another one. And for some patient, 300 milligrams per day is enough. but for other, you have to go to 1,200 milligram per day. So that will be certainly my first step. Check if you have a good dosage for the patient. In most of the case, if you don't have a good response, that's the reason. And then you just have to adapt the dose. I have no experience by using both treatment at the same time, but should be something useful in case of adverse events with hydroquinidine, because it's not always well tolerated. So perhaps if you can decrease hydroquinidine and then introduce flecainide, why not? Flecainide is usually also very efficient. So I have no clear answers for your question.
No, I understand. I will try ranolazine. We do have ranolazine, so I will try
you can also
ranolazine.
try ranolazine.
And my final question, if nobody else has questions, and I will let you go. Have you seen, given that these are SCN5A variants, have you seen in the same family all the phenotypes, long QT3 or Brugada? Because to me, it was, I think this was an incidental finding that he had the uncle with Brugada, but I was just wondering. Okay.
No. We performed some Ashmanin challenge at the beginning of the experience just because as we found an SCN5 mutation we want to see. For now, we stopped to do so, but we never found Brugada or long QT syndrome within this family.
Okay, so thank you. If nobody else wants to ask something, I'll let everybody go and have a nice evening. I think it was a fantastic webinar, very beautiful cases, very illustrative. I think we all take home that image, that typical ECG in our brain, so that next time that we see them, we can identify it right away. So thank you very much. I think it was very educative.
Thank you also for
Thank you.
the speakers. Yeah.
Thank you.